Thank you, everyone. At first, I'd like to thank you all for joining our TCTAP 2022. This session is a hot topic for the main and multivessel PCI. I am very honored to have a co-moderator, Patrick Suri here, many distinguished speakers here and panelists here. So Dr. Patrick will introduce the first part of main disease PCI versus bypass surgery session. Would you introduce Patrick?
Thank you, SJ. Yeah, it's a wonderful speakers and panel. Let me introduce the panel. We have Robert Byrne in Dublin, Ireland. You have your colleague Yuming An, which has been very important in many trials conducted in your place. We have Eval Christiansen from Noble, and you have Mark Sabatin in Boston from the TIMI group. Recently, we have put the 4 trials together, Pre-Combat, Noble, Excel, and Syntax. So the first speaker is Brian Bergmark from the Brigham and Women's Hospital in USA, and he's going to report about these patient-based meta-analysis that I was alluding to. So the most updated IPD meta-analysis for left main revascularization. Brian?
Great. So somebody please let me know if the slides are not showing up. Thank you very much for the opportunity to present here. It's a pleasure and I look forward to the discussion. So as Dr. Suri has noted, we'll be presenting here on a meta-analysis of PCI with drug-eluting stents versus CABG in patients with left main coronary disease. My disclosures are shown here. By way of brief background, data comparing PCI with drug-eluting stents versus CABG in patients with left main disease stem principally from 4 landmark trials: Syntax, and specifically the left main subgroup, Pre-Combat, Noble, and Excel. However, differences in trial composite endpoints and findings have led to persistent uncertainty regarding the optimal revascularization strategy. So a collaboration was formed between a group of independent investigators and the principal investigators of the 4 trials. 2 points here. 1, the independent investigator group was balanced with 1 cardiac surgeon and 1 interventional cardiologist. And 2, it was an act of great generosity and faith on the part of the trial PIs to undergo this collaboration, obviously having spent years of their lives in the design, conduct, and interpretation of these trials. Given the tenor of the conversation in this space, it is important for us to emphasize that the independent investigators created the statistical analysis plan, performed all analyses, drafted the manuscript, had complete control over the content, and vouched for the integrity of the analyses and the findings. A 1-stage meta-analytic approach was used on a combined data set of individual patient data supplied by each trial. The primary endpoint was all-cause mortality through 5 years. This endpoint was chosen because it is unambiguous and because it is the most clinically important outcome. There were 5 secondary endpoints: cardiovascular death, spontaneous MI, procedural MI, stroke, and repeat coronary revascularization. We intentionally disaggregated spontaneous and procedural MI. We performed landmark analyses, supplemental analyses using 10-year mortality data, which was available in the Syntax and Pre-Combat trials, as well as subgroup analyses. And finally, we performed Bayesian analyses to help quantify the probability and magnitude of any difference in mortality. These are the baseline and procedural characteristics. It is important to emphasize that all 4,394 patients were judged by a multidisciplinary team to be equally suitable candidates for either PCI or CABG as a criterion for enrollment in each of the 4 trials. The median age was 66. 3/4 of the patients were men. 1/4 had diabetes. A small portion had an EF less than 50%. The median Syntax score was about 25. 16% had left main only disease, and about half had left main plus at least 2 vessel disease. The median number of stents or conduits was 2. IVUS was used in about 2/3 of the PCIs, and a Lima graft in 96% of the bypass surgeries, and all arterial grafting in 23% of the surgeries. This figure shows the primary comparison here of mortality through 5 years, 11.2% after PCI, 10.2% after CABG. The hazard ratio is 1.10 with a 95% confidence interval of 0.91 to 1.32 and a p-value of 0.33. The absolute difference was 0.9% with a 95% confidence interval spanning 0 from negative 0.9 to 2.8%. Looking further into this mortality difference is the Bayesian analysis. The dotted line is centered at 0, indicating no difference between PCI and CABG, and anything to the right would indicate higher mortality after PCI. You can see that the curve is shifted overall to the right. To quantify this, there was an 86% probability that mortality was greater with PCI than CABG. That's any difference greater than 0. Looking at specific thresholds, there was a 49% probability that there was a mortality difference between PCI and CABG of at least 1% over 5 years, or 0.2% per year. And there was a 5% probability that there was a mortality difference of at least 2.5% over 5 years. So we interpreted this to mean that overall there was probably higher mortality with PCI, and that the absolute risk difference, more likely than not, was less than 0.2% per year. What about cardiovascular and non-cardiovascular mortality? As you can see here in the table, absolute difference of 0.4% for cardiovascular and 0.7% for non-cardiovascular, not significant for either, obviously. And here is the incidence curve for cardiovascular mortality, hazard ratio of 1.07, absolute difference of 0.4% or less than 0.1% per year. As noted, there were 2 trials with 10-year mortality data. After CABG, 22.1%, PCI 21.6%, hazard ratio of 0.96, p-value of 0.72. Looking at subgroups for mortality, this is a potentially fraught area with no adjustment for multiple testing. But given our knowledge from other settings of the importance of coronary anatomical complexity, we did look at this possible trend for benefit with CABG at higher syntax scores a little bit more deeply. Important to note that there was no significant interaction here with syntax score categorized by low, intermediate, and high scores. We did then look at syntax score continuously on the x-axis. This is the hazard ratio for cardiovascular mortality. On the y-axis, again, importantly, the interaction p-value is 0.15. Nonetheless, I think a reasonable person, taking into account knowledge we have from other settings, would wonder if there's an advantage with bypass surgery at higher syntax scores. This curve appears to depart hazard ratio of 1 right at a syntax score of about 33. MI and repeat revascularization, spontaneous MI is unequivocally higher after PCI, hazard ratio of 2.35, number needed to treat with bypass surgery to prevent 1 MI through 5 years is 29. Similar story for repeat revascularization, hazard ratio of 1.78, number needed to treat of 14. For procedural MI, shown here on the left is the procedural MI events defined according to each trial's protocol. These were lower after PCI, odds ratio of 0.61, p-value of 0.013. The protocol definitions for each trial tended to use CKMB and use a high symmetric threshold for PCI and CABG. 2 trials, Syntax and Excel, had procedural MI data based on the universal definition of MI, which favors troponin and uses asymmetric thresholds for PCI and CABG. There was no statistically significant difference in these 2 trials for procedural MI. And then stroke. Overall, through 5 years, there was no difference. Hazard ratio of 0.84, but there was a violation of the proportional hazards assumption, indicating unequal risk relationship throughout this period. Looking at just the first year, there was a significantly lower rate after PCI, hazard ratio of 0.37, and an absolute difference of 1%. And then there was no difference after 1 year, when I think it would be less likely to expect that initial revascularization strategy to manifest as a difference in incident stroke. So to summarize these data, comparing PCI with drug-eluting stents versus CABG in patients with left main coronary disease, a median syntax score of 25, and deemed equally suitable candidates for either revascularization approach, there was no statistically significant difference in survival at 5 years and 10 years. A Bayesian approach suggested a difference favoring CABG probably exists, and that it is more likely than not less than 0.2% per year in magnitude. And a possible cardiovascular mortality benefit of CABG appeared confined to patients with high syntax scores. Rates of spontaneous MI and repeat revascularization are lower after CABG, and there was a lower rate of early stroke after PCI. Differences in the risk of procedural MI depended on the definition used. So where do we go from here? This will be, of course, a topic of discussion for the group, but just some brief thoughts. One, these findings apply to a subset of patients with left main disease. Two, a large trial with latest surgical and PCI techniques would be nice, but one, it is difficult to achieve adequate power for mortality difference. And so by the time such a trial were designed, enrolled, and we had 5 or 10 year mortality data, we'd be quite some time out from now, of course. And so we need to work with what we've got in the meantime. And secondly, there is always going to be a tension between long-term follow-up and state-of-the-art revascularization, whether regarding PCI techniques, intracoronary imaging, or surgical techniques. But I'd actually say that perhaps refining the mortality difference point estimate is not the major issue. I think for anybody who takes part in these conversations on a regular basis, if we, with more confidence, said that the mortality difference is 0.15% per year, or 0.3% per year, that wouldn't meaningfully alter the conversations we have. That the majority of the time patients bring to this conversation their priorities that are often not particularly well informed by our data set. For example, they might want the option that is least likely to result in dialysis, for which we don't have a lot of data. And so really the issue is, how do we balance patient values and preferences with the small number of hard outcomes for which we have data and which have been highlighted here in this meta-analysis. And so integrating these findings into patient-centered decision-making is the central challenge moving forward. I look forward to the conversation for the rest of the session, and appreciate the opportunity to present this work. Thank you.
Thank you very much, Brian. That was a crystal clear report of these meta-analysis. The next two speakers, Greg Stone and John Puskas, it doesn't look like a debate, but clearly it's two different positions. One is entitled by Greg, Left Main Revascularization Data Support PCI in Most Cases. That will be Greg, Mount Sinai Cardiovascular Research Foundation. And the next will be John Puskas with CABG remain the best therapy for most patients with left main disease. But let's start by Greg. Greg, you have the floor.
Okay. Well, thank you, Patrick. And John and I have discussed this many times, and we agree more than we disagree. So I think you'll be hearing the same data with slightly different perspectives. But I do believe that the data supports PCI in most cases, although we don't have data for every question that's important to inform this decision. I have no direct financial relationships with any of the stent manufacturers. So class 1 in the guidelines, and everybody agrees, is that for difficult decisions for patients with cardiovascular disease, we should be using a heart team approach, where we bring together all the different specialists to bear, including general cardiologists, interventionalists, surgeons. And the purpose of the heart team is to inform the patient. It's to help the patient achieve their goals of clearing their bar. It's not to get one of the subspecialists over the goal line, but it's really to inform the patient. And there's been a lot said, a lot written in the last decade or so about the importance in patient preferences and the principle of autonomy, which states that the well-informed patient should be able to make and guide their own treatment decisions. So what outcomes matter to patients? And they're often actually different than what matters to doctors. Look, we'll start what's obvious. Most patients would much rather undergo PCI than CABG because of the early differences in invasiveness and recovery, et cetera. And I'll come to that later. But let's just look at hard outcomes. There have been several series that have been published. And when you look at cardiovascular physicians, they would rate mortality being the most important adverse outcome. Hard to argue that. They then think that stroke and large MI is probably about half as important as mortality, and other endpoints such as revascularization and rehospitalization are much less important to physicians. But when you ask patients the same question, while they also put a great priority on survival, they think that large MI and stroke are at least as important as is living longer. And they agree, though, that these other endpoints are of lesser importance. So then let's ask, is mortality different? And right now, the absolute best data set is the data set that you just saw. And that is all of the contemporary data from drug-eluting stents versus bypass surgery, a total of 4,394 patients that was independently analyzed by the TIMI group with a primary endpoint of all-cause mortality, and there's no significant difference in all-cause mortality. The difference, any risk difference was quite small, and you saw the Bayesian analysis discussion, which I think is tremendously useful because it takes this non-significance and it points out if there was a difference, if you enrolled more patients, what would the likely difference be? Of course, there could certainly be non-significance, or it could even slightly favor PCI, but more likely than not, the absolute risk difference was less than 0.2% per year in all-cause mortality. That's 1 in 500 patients per year. So it's the outcomes are very, very similar. And the improvement compared to what we would expect with medical therapy, even though we don't have contemporary trials, if you remember, there used to be about a 30 to 40% survival benefit over a several-year period with bypass surgery compared to medical therapy. So PCI and CABG in that regard are very similar in terms of their improvement. Cardiovascular mortality is what you would really expect PCI versus CABG to affect. And here you can see there's even less of a difference. It's likely less than 0.1% per year. And you see that the curves are converging in 5 years. And then if you look at the 10-year mortality data from 2 trials, this is all-cause mortality, absolutely no difference between the two. And again, the curves are converging over 10 years. So nothing to suggest that longer-term follow-up is going to change this discussion. You saw the subgroup analysis. Interestingly, there were no significant interactions, including with a syntax score of greater than or equal to 33. And about 25% of the patients enrolled in the trial had a high syntax score. But while there was no relationship between all-cause mortality and syntax score, when you break it down into cardiovascular mortality, you saw this curve. This is the spline analysis. And you can see here, importantly, up to a syntax score of 33, there's absolutely no difference in mortality. If anything, you can see the point estimate is slightly below the line of unity favoring PCI, but clearly no difference. Then after 33, I do believe there's an increasing benefit for bypass surgery. And when you got to about, with this data set in nearly 4,400 patients, when you got to about 45, that's when it became significant. So there's not much difference from 33 to 37 or 38, but once you get up to 40 or above, yeah, then there's a difference, I believe. Now, what about stroke? The second most important endpoint, you saw this data as well. There's clearly about a 1% stroke difference. Absolute stroke difference favoring PCI over CABG in the periprocedural period, which continues out to 1 year. So it's a real difference. I don't want to make too big a deal of it. It's 1 in 100 patients. For some higher risk patients, perhaps those with cerebrovascular disease or a calcific aorta, in whom the stroke rates might be higher, that may be even more significant. For patients who are terrified of stroke, this may be a significant number, but it's a small difference, but it's real. And then the curves show no significant difference long-term because of the accrual of events in both arms, and because of an inexplicably higher long-term rate of stroke after Noble compared to PCI, mostly between 2 and 5 years. And then what about myocardial infarction? Well, if you look at the large MIs, and that's the protocol definition, and of course you always have to go by the protocol definition. These were the large MIs where there was not ascertainment bias because the definitions were same in both arms, and they were large elevations of CKMB, and in some cases Q waves. There was about a 1.5% reduction in large periprocedural MIs with PCI compared to CABG, but there's clearly a higher rate of spontaneous MIs with CABG compared to with PCI compared to CABG as well. Now, what about all these other outcomes? Recurrent angina, chest pain, musculoskeletal disorders, atrial fibrillation, renal dysfunction, dialysis, which Brian mentioned, vascular complications, major bleeding, repeat revascularization, rehospitalizations, cognitive decline, time to recovery. Some of these may be much more important to certain patients than certainly biomarker elevations like myocardial infarction. How do we incorporate all of these? Well, it's said many, many times that in general, patients want to live longer and live better. And really, those are the two metrics we should be looking at. And in fact, quality of life is the metric of living better. And quality of life encapsulates all of those non-fatal outcomes. So really, we can look at just survival and improvement in quality of life. And there's been one formal quality of life assessment in left main PCI versus CABG, and that was from the XL trial. And if you look at what happens within the 30 days, this actually explains why most patients want to undergo PCI rather than CABG. I don't even think John is going to argue it's a much less invasive procedure. So if you look at all the major complications, not only just death and stroke and MI, but also even repeat revascularization, major bleeding, major arrhythmias, AFib requiring chronic oral anticoagulation, repeat procedures, renal failure, sternal wound dehiscence, prolonged intubation, et cetera, it's 3 times to 4 times more likely to occur after CABG. And we just quantified this in the Excel trial. So when you look at formal quality of life, this basically quantifies what patients know inherently, that after PCI, they're immediately feeling better. This is the SF-12 physical summary score, where within the first month after CABG, let's be honest, patients are feeling worse. It takes somewhere between 1 and 6 months for most patients to really recover. So by 12 months, they've completely caught up. And now the physical summary scores are much improved with both procedures without significant differences over time. Similarly, if you look at dyspnea, within a month and somewhere between 1 and 12 months, patients are more short of breath after bypass surgery. But then there's a catch-up, and then it's the same. When you look at mental functioning, it takes a while, even from a mental point of view, to recover from surgery. And there's not a decline in cognitive function, but there's not as rapid a recovery and improvement as with PCI, although then there's a long-term catch-up. And finally, depression. More patients are depressed after bypass surgery than after PCI, and this lasts for more than a year to recover. So this is what patients know. These are the big quality of life differences, and these cannot be discarded. In fact, we can't say for, oh gosh, for a 1 out of 500 survival benefit, patients, you have to go through all this. Patients need to make their own informed decisions. And finally, in terms of the disease-specific outcomes like angina frequency, both procedures are excellent at resolving angina in left main coronary disease. You can see at 1 month, the SAC angina score was slightly better after PCI than CABG. That's probably, I suspect, because some musculoskeletal pain is being misclassified as angina in some of the CABG patients. But then if you look at 12 and 36 months, the curves are almost superimposable. And notice how much better they are compared to where they start. Both procedures almost make patients angina-free with left main disease. Now, John will rightly point out, and others will say, but there are many patients who are not eligible for randomization because it's obvious they should undergo bypass surgery. And I agree with that. And that's why we performed a very careful registry in the XL trial. And we did this for the first 1,000 patients who were not randomized. So during that period, 747 patients were randomized and 1,000 patients were not. And if you look at why they were not randomized, probably the most common reasons were because they had too complex coronary disease, high syntax scores, or the heart team felt that they could not undergo PCI. But there were also a substantial number of patients who could not undergo CABG. So if you looked at how registry patients were treated, about 2/3 of them were treated with CABG and about 1/3 were treated with PCI. So the bottom line is during the enrollment of the registry period, the total numbers are that 38% were eligible for CABG only, and 20% were eligible only for PCI. So there is, and again, the main PCI ineligibility was complexity of coronary disease. The main CABG of ineligibility was clinical comorbidities, frailty, COPD, prior stroke, etc. So there clearly is a role for both procedures, even in patients who cannot undergo one or the other. So there are many cases that are so obvious. Isolated osteo left main with normal coronary arteries, it would be, in my mind, insane to do bypass surgery in this patient. But you look at the patient on the right with a syntax score of 52, and triple vessel disease, multiple total occlusions. Patrick will remember this patient because this patient was randomized in the syntax trial. So that's really hubris. But for many, many other patients, there is equipoise, and we need to inform the patients about the risks and benefits. So in summary, if you're evidence-based and you put patients first, for left main revascularization, I do believe the data support PCI in most cases when equipoise is present. And I like this slide from the TIMI study group saying that the nuances of the data emphasize the importance of the heart team approach to assist patients in reaching a treatment decision that is best for them. Thank you very much.
Thank you very much, Greg, for blending these meta-analysis of the TIMI group with your personal observation derived from the Excel, which are numerous and very important. Now we have our surgeon, John Puskas, Mount Sinai, St. Luke's, USA, with the title, CABG remains the best therapy for most patients with left main disease. John?
So I was assigned the topic that coronary bypass remains the best therapy for most patients with left main stenosis. And I think that that is a literally and mathematically true statement. And it really hinges upon the importance of the highly selective nature of the patient population enrolled in these randomized trials that we've been hearing about earlier today. These are my disclosures. One of them is that Greg is my friend and colleague, and it's okay that we don't always agree on everything. I first was asked to talk about this topic with Greg at TCT in 2017, and this is my title slide, that Excel and Noble prove that PCI is far from being an acceptable alternative to CABG for left main revascularization, with the exception of a small proportion of patients. I think that argument still holds true. This is Excel, 2,900 patients with unprotected left main disease and a syntax score less than 33. As you heard from Greg, in the first 1,700, more than half were not felt to be eligible for randomization due to lack of equipoise, and 1,000 of those 1,700 were enrolled in the registry. We had planned to enroll 2,600 people in the randomized cohorts, but only enrolled 1,900. Half received drug-eluting stenting and half received coronary bypass. And the primary endpoint was measured at a minimum follow-up of 2 years and a median of 3 years, which quite frankly is way too short to see the advantage of CABG over PCI. Greg showed this slide earlier, and I think it's an important one because you see that ineligibility for PCI excluded more than 1/3 of patients. Ineligibility for CABG excluded 17%. And among those 1,000 patients in the first 1,700 in the Excel trial, 2/3 underwent coronary bypass. And I think this is basically reflects the proportion of patients with left main disease who also have 2 or 3 vessel disease in addition to their left main. You'll see a slide later from Syntax that looks a very great deal like this. And it's on that basis that I would argue that most patients with left main stenosis should have CABG, because most patients with left main stenosis also have complex other coronary disease. In the PCI patients enrolled in the Excel trial, about just less than 2 lesions per patient were treated. While patients having coronary bypass in Excel, 2.6 distal anastomoses were done, suggesting a difference in completeness of revascularization. Now, there was also a difference in discharge medications. About twofold more patients in the PCI arm had dual antiplatelet therapy than in the CABG arm. And I think this is an important theme that we can all agree on. Coronary bypass patients need optimal medical therapy, guidelines-directed medical therapy, and commonly do not receive it, even in randomized trials that are monitored and carefully conducted. So this is an important opportunity for improvement for patient care. At 3 years, we saw a significant difference in outcomes between these two groups in some categories. Some didn't reach statistical significance, but you can see that there was a strong trend towards more mortality in the PCI group, a similar number of strokes, and no difference in myocardial infarction. Ischemia-driven revascularization and all revascularization were about twice as common in PCI. This is an important concept, and Greg has commented on this. In the early days after intervention, coronary bypass patients have more complications than PCI patients. After 30 days, the opposite occurs. And this, I think, fundamentally gets to the point that patients who have a long life expectancy are much more likely to benefit from multivessel, perhaps multi-arterial bypass grafting, and patients who have a short life expectancy may in fact receive very similar benefit or greater benefit from PCI than from CABG. And that gets me to the conclusion that I would like to emphasize, and that is I think we do too much coronary bypass for frail old people. I think we do too much multivessel PCI for young diabetic patients who should receive 3 or 4 arterial grafts. This is the primary endpoint at 3 years for the XL trial. And this was a slide I showed at TCT with Greg. And I asked the simple question, while everyone was applauding the fact that this was not statistically significant at 3 years, which curve would you rather be on? What would these curves look like at 5 years? And is this the future of XL? Because those curves look to me like the curves I remember from the Freedom trial, where over the first 2 or 3 years, there wasn't a big difference, but by 5 years, the difference in the primary endpoint of death, stroke, or MI, not including repeat revascularization, was in favor of CABG, and these curves were not just diverging, the rate of the divergence was accelerating over time. These are the concluding sentences, one from Patrick Sorois, one of our panelists today, commenting on the outcomes from Syntax at 1 and 5 years. CABG remains a standard of care for patients with 3-vessel or left main coronary disease, and then CABG should remain the standard of care for patients with complex lesions, high or intermediate Syntax scores. At 5 years, in this important paper identifying the causes of death in the Syntax cohorts, we saw that the treatment with PCI versus CABG was an independent predictor of cardiac death with an odds ratio of 1.55. And that difference in MI-related death was largely seen in patients with diabetes, 3-vessel disease, or high Syntax score. Now here's the 5-year paper from XL, published in the New England Journal. You see both Greg and I are co-authors. It is, in fact, and remains the largest, perhaps most definitive trial of CABG versus PCI in selected patients with Syntax scores less than 33. But I have some significant concerns about the reporting of XL, the interpretation and lack of emphasis on the mortality data, the delay in us publishing our outcomes with respect to the alternative predefined definitions of periprocedural MI and the statistical analysis. Here we see accelerating mortality with PCI at 5 years in the relatively low-risk patients enrolled in the XL trial. PCI at 5 years was associated with a significant 38% increase in death, in non-procedural myocardial infarction, and a repeat revascularization without a difference in stroke. Mario Gaudino and others looked at this sort of hypothetical reanalysis of XL, excluding periprocedural MI, as was done in the Nobel trial. And you can see that CABG was the clear winner for the composite primary endpoint and for the individual components of death, non-procedural MI, and repeat revascularization. Greg and others in this paper, which came out a year following the 5-year data from XL, identified as well from our available database that the definition used for periprocedural MI had an immense impact on the primary composite endpoint. Frankly, it went from a negative 2-fold to a positive 2-fold against CABG for one definition and for CABG in the other definition. This is a JACC paper, also from 2020, Patrick Sorois, again, one of the co-authors here. And you can see that, again, the definition had the greatest impact on the primary composite endpoint, the definition for peri-procedural MI. It's 2 to 1 with one definition and 1 to 2 with the other definition. That's not news. This was known when the trial was designed. Here's Greg and Stuart Pocock discussing the fact that the least clinically relevant composite component may in fact drive event rates, and that could be enzymatic myocardial infarction. The 3-year data for XL were published with a non-inferiority comparison, the 5-year data with a superiority comparison. Had we used non-inferiority for the 5-year outcome, the publication would have had a very different message. Now here's Noble. Dr. Christensen is on our panel. This is the other major prospective randomized trial of CABG versus PCI and unprotected left main stenosis. MACE, that's death, stroke, non-procedural MI or repeat revascularization was the primary endpoint, about 600 patients in each group. Interestingly, almost 7% of patients did not receive a internal mammary graft to the LED. But despite that, CABG versus PCI had a, well, PCI was non-inferior, did not meet the non-inferior goal for MACE. And you can see about a 10% difference over 5 years in the MACE primary composite outcome in favor of CABG. All-cause mortality did not reach statistical significance, but began to diverge at 5 years. Non-procedural myocardial infarction was about 3-fold in favor of CABG. Repeat revascularization hazard ratio 1.5 in favor of CABG. Stroke, unusual for some of these trials, again, 2-fold in favor of CABG. So you can see these are the conclusions from the Noble trial. PCI did not meet non-inferiority. It resulted in higher rates of non-procedural MI and revascularization, and mortality was similar. This is a JTCVS paper, Dr. Farku, Nick Fremantle, Mario Gardino, looking at syntaxes through 12 years follow-up, XL and Noble at 5 years, and the pooled analysis. Again, favoring coronary bypass in these selected left main patients with syntax score less than 33. Jim Brophy, a Bayesian analysis in JAMA, looking at the XL data, concluding that based on XL results alone or taking the totality of available evidence, PCI was associated with inferior long-term results for all events, including mortality compared with CABG for patients with left main coronary disease. Can the left main be stented? Absolutely, but can does not equal should. It's certainly not in all cases. I do believe, as Greg does, that there are patients who should have left main stenting, but I think the majority should have coronary bypass. And why is it that CABG is better than PCI? Well, PCI treats an isolated flow limiting lesion, but CABG bypasses the proximal 2/3 or more of the vessel, where present and future threatening lesions can occur. Especially with left main stenosis, the downstream region that's at risk is very large, and the coronary bypass advantage will persist. This is a slide that looks a lot like that registry slide from the XL trial. You see in syntax, patients with left main and 3-vessel disease were over 1/3, and left main and 2-vessel disease approximately 1/3. So roughly 2/3 of patients with left main disease have at least 2-vessel or 3-vessel coronary disease in addition. How do patients with multivessel coronary disease fare with PCI versus CABG? Well, here's the most up-to-date, state-of-the-art PCI versus CABG comparison, FAME3, published just very recently in New England Journal. PCI guided by FFR, CABG guided by angiography. And you can see at 1 year, PCI fails non-inferiority testing. And in fact, the adverse MACE events are diverging and visibly so in favor of CABG. In that FAME3 trial, you can see that almost no group is trending to have a better outcome with PCI. The large majority of groups are favoring CABG. And death from cardiac causes, 0.5% for CABG, 0.8% for PCI. All of these outcomes are favoring CABG over PCI. And this is the conclusion that in patients with 3-vessel disease, FFR-guided PCI was not found to be inferior to CABG with respect to the incidence of the composite of death, MI, stroke, or repeat revascularization at just 1 year. Fred Welt, cardiologist, invited commentary on FAME3, makes this comment: FFR-guided PCI does not result in outcomes as good as those of CABG for patients with angiographically defined multivessel coronary disease. And as I pointed out, 2/3 of patients with left main disease have angiographically defined multivessel coronary disease. So in conclusion, the risk of CABG is related to patient-related factors, and those are important, as Greg pointed out, and they do impact patient preferences. They impact surgical risk and adverse outcomes, especially in those first 30 days. The risk of PCI is related to CAD complexity. The majority of patients with left main disease, roughly 2/3, have high CAD complexity in addition to their left main disease, and as a result are best treated with surgery. Patients with an isolated left main stenosis, especially that one that Greg showed, I think can have a very successful PCI. But most left main patients have complex other coronary disease and are best treated with surgery. PCI for left main is most appropriate for patients with isolated left main disease and those with limited life expectancy or elevated risk factors for CABG. There is another alternative. It's not fish or fowl. There is a hybrid option as well. And this is one that I've enjoyed participating in a very heart team approach with my colleagues at Emory and here at Mount Sinai, a hybrid revascularization in which we do a robotic, minimally invasive internal mammary to the LAD and then stent the left main through the distal left main bifurcation into the circumflex system, yielding a very nice complete revascularization with a minimally invasive approach. Perhaps that, for some patients, may be the best of both worlds. Thank you.
Thank you very much, John. So really, we have heard a lot of data and argument. I think the time for discussion is unfortunately limited, but SJ will tell us how much minutes we can discuss. My impression is listening to the 3 speakers and elaborating a little bit on the conclusion of Brian is that this morning, this afternoon of, I don't know the real time, we have been most of the time talking about the average treatment effect. Even in the Bayesian analysis, it's a probabilistic assessment of the average treatment effect. But basically, when we are in our outpatient clinic in front of one patient, what's really is important, and it was alluded by Brian, is the individualized, personalized vital prognosis. I think we all agree that duration of life is important and a pleasant life is important. So the question that I have to the speaker and to the panel is how to move forward, because really we have to identify on an individual basis what will be the benefit for that patient which is in front of me. And I don't see too much progress or too much answer to that question. It's amazing for me that something as simple as the anatomic syntax score resists the test of the time when you look at the spline analysis. I mean, it's really at 33 that surgery is taking its takeoff, and obviously these patients benefit below 33. It looks okay for PCI, but that's only one component. How can we move forward to individualize the prognosis and to predict the individual benefit of a patient, PCI versus surgery? Who want to take that question first? Maybe we should give that to Brian and then to Greg and then to John, and then if we have time, and we must have time, the panel can make a comment about average treatment effect versus personalized prediction of prognosis. Brian.
Thank you. Thank you very much. Yeah, and I'll look forward to hearing Greg and John's thoughts on this. Obviously, they've generated a large amount of the data in this space, and listening to both of their talks, it to me came down to a similar point and issue, which is looking at the large denominator of all patients versus those among whom there's equipoise. But ultimately, the data that Dr. Stone showed from Excel, I think, start to get at what are these issues that really are impactful for patients? How do we quantify them? And how do we emphasize each of those specifically for each individual patient? And as you note, this does translating this probabilistic information into a binary decision for each individual patient is ultimately something that needs to be done, and we aren't going to have data that can do that for us. And it comes down fundamentally to listening to patients, I think, starting with the question of what is important to them in this process, and then starting to pull in the data we have from there. But I know our time is short, and I'll look forward to the other comments.
Very good, very good. Greg, a comment on that.
Yeah, so critically important because, of course, all of these trials give you aggregate outcomes for large populations. And within those large populations, there are some patients who are benefited, some patients who are harmed, and some patients who have very similar outcomes. And among for example, the harm group, some people are very harmed and other people are only harmed a minor amount. So if I have left main disease today, I'm thinking, okay, I am the age that I am, and I'm thinking I have likely this many years left, and I know the kind of hit I'm going to have to take in quality of life up front. And so I want to know, what are my long-term benefits going to be? Am I to give up 1 to 3 or 5 months of my life and having a worse quality of life? I want to know how much longer am I going to make that up on the back end? And that really is, for an individual, it's very hard to get that out of the data. You did one of the most beautiful analyses of the syntax score from the original syntax trial published in the Lancet. And you remember, just even from your data set, how much noise there is in the data, how much uncertainty there is. So I think that to be able to make some of these individualized predictions, which are also, again, by the way, very local hospital dependent and local operator dependent, in addition to the local patient dependence, we're going to need mega data sets, millions of patients. And this is where artificial intelligence and neural nets may be able to help define more precisely. But even then, you're only going to tell the patient, these are your likely outcomes. There's always going to be a confidence interval about what might happen for any individual patient.
Good. John, what comments on that? I think we all agree that there is a missing piece of the puzzle there for the individual.
Absolutely, and this is where the art of medicine and surgery comes in. It's not just the science. It's certainly not just the mathematics. I think we have to be very cautious drawing very generalized conclusions from multiple randomized trials that enroll highly selected patients. When we have more than half the patients going into registry in the syntax trial, and we recognize that even those enrolled have a specific predetermined upper limit for their complexity of disease. When we then take the results of that trial and generalize them to all patients with left main, which is common, we're on very uncertain ground. Greg is absolutely right in looking at the upfront cost of surgery versus PCI compared to the downstream benefit. I think that as we calculate the upfront cost of PCI, the syntax score is a very important tool. And one of the several reasons why I'm dismayed at the recent publication from ACC-AHA SCI, which downgrades the utility or importance of calculating a syntax score. I think we should be doing syntax score. I think we should be thinking about mathematically or arithmetically calculating the complexity or describing the complexity of coronary disease. And we should be also looking at the scores that we have for patient comorbidities, because those impact outcomes and the incidence of adverse events with coronary bypass. And then we have to look at the patient and listen to the patient. I especially look at the patient. If you come into my office with a walker or 2 canes, I'm going to send you to my friend down the hall in the cath lab. You're not having a coronary bypass operation. But I often see patients come in my office, they're 50 years old and they've had 5 stents and they're diabetic. And now we've got, a full metal jacket in 2 of the 3 vessels. And both those scenarios should be less common than they are. And I think if we work together, we will assign the right patients to the right therapies. And that should be the goal of the heart team.
Very good. Very good. I think we are running out of time, but let's give all the members of the panel a short statement additional to what has been said. Maybe start by Robert Byrne. What do you have to add to what has been said by the 3 speakers?
I suppose the only thing to add, and we heard it in a number of the presentations, is the complexity of the data that we're faced with. And sometimes when you show this to people outside the area, they say, well, how do you ever advise patients to decide between the 2 therapies? But I would say that Mark and Brian's analysis has removed a lot of the ambiguity, and pooling the data together gives us gives us a more accurate idea of where we are. In terms of how to involve the patients in decision making, I think we need to involve them in clinical practice guidelines. I think we need to provide them with visual aids to help them make these decisions and to factor in their personal preferences.
Very good. Young-Min Han, any additional comment?
No, I think I had one additional comment. I assume that what is the big difference between the low syntax score and high syntax score in the left main disease? I believe that it came from the non-left main disease. So considering the multivessel disease, bypass surgery, and PCI outcomes, so we can similarly apply to this concept of the left main disease. In my practice, even though very complex left main disease, the non-left main disease is very simple. I think that we can apply the PCI according to the operator experience. But left main disease is very complex. I think the bypass surgery would be a good option.
Very good. Evald?
Yeah, I agree on much of what had been said, but I think we should think in the way that they are not competitive. The control arm is medical treatment, and that is a very bad prognosis. So we talk to the patient and say that we have a good treatment for you, and we have 2 options, but the patient should be aware what they are buying. As Greg said, if they buy the surgery, they buy investment now in the next few weeks, and maybe a minor benefit in the long term. If you buy the PCI arm, you are discharged tomorrow, but you have increased risk of coming back to have another PCI. And I think patients understand that. According to syntax score, I'm a little reluctant to use that in detail for the individual patient, because remember in Excel, you have to up-classify 1 out of 3 to above 33 when they came to the core lab. So we look at the coronaries and the surgeon say, I can do a good graft to this LAD. This has a good runoff, or if there is a diffuse disease, I think maybe it's better for PCI. So we individualize, and we don't use the figure in the individual patient. I think we can use that in groups when we compare trials. So involve the patient.
Very good. So Mark, you have the difficult task to have the last word after all these good comments, but I'm sure you will find something additional.
Yeah, no, well, thanks. 3 fabulous talks. I mean, for me, I think the take-home points are, 1, that the patients studied in these 4 trials are not the entire universe of left main patients, right? There already was some sub-selection that happened. These were patients in whom that there was equipoise. So people need to go into this appreciating that. 2, that if we look within the patients who were then randomized, cardiovascular mortality is similar, but I think most would agree, as Brian showed, that as you get to higher complexity, that CABG does better, and I think that is fairly well established. As for the other outcomes, in addition to using syntax score for anatomic complexity, we're now using additional risk scores, and Patrick has obviously been a leader in this for having other factors. patient comorbidities that can hopefully give us additional information to subset the patients in terms of risk of other important outcomes, including stroke and spontaneous MI, and probably revas being the least important. So it's a wonderful data set that obviously many people on this call contributed to. We will continue to analyze it and try to provide additional data so we can inform for specific patient subsets what would be the preferable option.
Excellent. SJ, you can continue the session. Maybe you have an
All right,
additional comment
I got
personally.
a simple comment for that. Dr. Puskas, anyway, you clearly demonstrate, main isolated sharp disease is clear, right? Stain is okay, right? It's one of the good alternative for surgery. The meaning is remaining meta on any main disease study have some, difference in PCI versus surgery. Mainly related with a combined multivessel disease, right? So still clear, we got some, concept, main intervention is usually okay. However, remaining downstream disease, multivessel disease, how can we treat them completely vascular, incomplete vascular, how much complexity, depending on the different operators, if feasibility concern, big vessel, small vessel, lots of issues, right, for the multivessel disease. And so if you look in details, any main study, still we have struggling with a combined multivessel disease subset, right? So I think so. And so we're gonna have some more exciting, issues in the next session. So we're gonna move to multivessel treatment. What changes in the real practice after the new guideline? So William Firon will give us first talk, role of PCI in multivessel disease.
Thank you for the opportunity to speak about FFR guided PCI for multivessel coronary disease in 2022. These are my disclosures. So in 2021, 3 major FFR guided PCI trials in patients with multivessel coronary disease were either presented or published. The FUTURE study, the FLOWER MI study, and the FAME-3 trial. And some have interpreted these as all negative trials for FFR or coronary physiology. But what I would like to try to do is convince you that that's not necessarily the case. So let's talk about the FUTURE trial first. This was a study looking at FFR guided therapy in multivessel coronary disease patients. And these patients were randomly assigned to an FFR guided approach to therapy, either medical therapy or PCI or CABG, or an angio-guided approach to deciding which therapy to apply. The primary endpoint was major adverse cardiac and cerebrovascular events at 1 year. The study was stopped prematurely after enrollment of 927 patients because of a signal for increased mortality in the FFR guided group. However, the primary endpoint you see at 1 year was identical between the 2 treatment strategies. And when the investigators followed out the mortality rates in both groups to a longer time period, you see there was no difference in mortality either. And likely the early signal was the play of chance. So some have asked, well, why didn't FFR guided therapy outperform angio guided therapy like what was seen in FAME-1? And I think there are a few reasons. First, this is a fairly complex patient population with a relatively high syntax score, 19, and more than 50% of patients had 3-vessel coronary disease. In addition, 127 lesions with an FFR above 0.80, negative FFRs, received PCI anyway. And this was 27% of all of the FFR negative lesions. The study was underpowered with just 54% of the planned population enrolled. And finally, only 8% of patients received a different treatment in the 2 groups. And what I mean by that is if you look at the angio-guided group here and the FFR-guided group, As far as those assigned to optimal medical therapy, it was 9% in the angio-guided group and 17% in FFR guided. So an 8% difference. The number assigned to CABG was essentially identical, which is surprising. One would think that FFR guidance would downgrade some 3-vessel disease patients to 1 or 2-vessel disease. And finally, those assigned to PCI was 8% higher in the angio-guided group. So only 8% of patients, or 35 to 40, in the FFR-guided group received a different treatment, OMT, instead of PCI than in the angio-guided group, which makes it hard to demonstrate any difference in outcomes. Let's now talk a bit about the FLOWER MI study. This was a study looking at FFR-guided PCI in STEMI patients with multivessel coronary disease. Over 1,100 patients with STEMI who underwent successful primary PCI and had at least one other major vessel with a 50% or greater narrowing were randomized to either FFR-guided complete revascularization or angio-guided complete revascularization. The primary endpoint was death, MI, or unplanned hospitalization with urgent revascularization at 1 year. And what we see is that there was no difference in the rate of death, MI, or hospitalization, particularly if you look at the top curve here on the 100 scale. If you look on this really zoomed in scale, which is a bit misleading, it makes you think there might be a difference, but really there was no difference with broad confidence intervals. Now, when you look at the individual components of the primary endpoint, one sees that there were 18 non-fatal MIs, or 3.1% in the FFR-guided group, and 10, or 1.7% in the angio-guided group. But what is mentioned in the subtext is that procedural MI actually was diagnosed in 7% or 7 patients in the FFR guided arm and only 2 patients in the angio guided arm, which is a bit unclear, especially when the angio guided group had 260 more lesions treated with PCI. Some other trial design considerations that are worth highlighting. It would have been ideal if randomization occurred after the operators had identified and stated which non-culprit lesions would be treated. Instead, there were more lesions identified in the FFR guided arm, 980, almost 100 more, compared to 891 in the angio guided arm. And this can explain why the contrast usage and the procedure time were similar between the groups. One would have expected these to be less contrast and shorter procedures with FFR, as has been shown in other studies. But this was not the case because so many more lesions were interrogated in the FFR guided group. In addition, of those 980 lesions identified in the FFR guided arm, the FFR value was missing in 154 patients. And there were 460 lesions with a low FFR, yet PCI was performed in 546 lesions in the FFR guided arm. So there were a fair number of patients who had a negative FFR yet received PCI anyway. And this may explain why an average of 1.1 stents were placed in the non-culprit lesions in the FFR guided arm compared with 1.5 in the angio guided arm, which is a fairly similar number of stents. In addition, it would have been ideal if FFR had also been measured in a blinded fashion in the angio-guided patients. And the reason this would have been helpful is it would have allowed a comparison of PCI versus medical therapy for non-culprit lesions with negative FFR. Unfortunately, in the angio-guided arm, we don't know which lesions had a negative FFR, and so we can't make this comparison. So was FLOWER MI a negative trial for FFR, or should we have expected better outcomes with FFR in this STEMI population? Well, first of all, both groups were presenting with a STEMI and underwent primary PCI, which was likely the most important indicator of outcomes and was similar in both groups. So we would expect a similar outcome from that. 66% of the FFR guided patients underwent non-culprit PCI, similar to what was seen in the angio-guided group, and 3% of the angio-guided patients did not have non-culprit PCI. So basically, these were the crossover rate. And in these crossovers, you would expect, again, a similar outcome. So because of this, just under 200 patients in the FFR guided arm did not have non-culprit PCI and could potentially contribute to a different outcome. So a very small number when you look at that in relation to the total patient population. Now I'd like to spend a few minutes talking about FAME-3. This was a study comparing FFR guided PCI with CABG in patients with 3-vessel coronary disease, not involving the left main. And 1,500 patients were randomized to FFR guided PCI with current generation DES or to bypass. The primary endpoint was the rate of major adverse cardiac and cerebral vascular events, death, MI, stroke, or repeat revascularization at 1 year. The non-inferiority margin was set at a hazard ratio of 1.65. Baseline characteristics are shown here. The average age was 65. Predominantly white men were enrolled with typical risk factors. About 30% had diabetes and 40% were presenting with an acute coronary syndrome. As far as procedural characteristics, the time to procedure, the procedure duration, and the length of hospital stay were all lower or shorter in the PCI arm compared to the CABG arm. The number of lesions was just over 4 and similar between both groups. About 20% had chronic total occlusions and about 2/3 had a bifurcation lesion. The mean syntax score was 26 in both groups. The primary endpoint again was MACE at 1 year. And what you see was that it was 10.6% in the PCI arm and 6.9% in the CABG arm, with a hazard ratio of 1.5 and an upper bound of 95% confidence interval at 2.2, which was above the non-inferiority margin of 1.65. So this trial did not meet the preset criterion for non-inferiority. When looking at the secondary endpoints, the individual components of the primary outcome, there were no significant differences in death, MI, stroke, or repeat revascularization, or in the composite of death, MI, or stroke, although it was numerically higher after PCI. Safety endpoints occurred significantly less frequently in the PCI group. So severe bleeding, acute kidney injury, and atrial fibrillation were all lower. Fortunately, definite stent thrombosis and symptomatic graft occlusion were both rare occurrences, and rehospitalization within 30 days occurred less frequently after PCI. Now, there was an important interaction with respect to outcomes based on the syntax score. And shown here are the patients who had a low syntax score. And you see that FFR guided PCI actually numerically was better than CABG in this cohort. Whereas in those with an intermediate and a high syntax score, CABG outperformed FFR guided PCI. Was FAME-3 a negative trial for FFR? Well, I think it's important to remember that only 24% of lesions in the FFR guided patients had an FFR above 0.80. 21% of patients had a CTO, and the mean syntax score was 26. In patients with such complex disease where FFR will be mostly positive, and where we know from previous studies CABG outperforms PCI, FFR guided PCI is less likely to have a benefit or to be able to show a benefit. Now, an important message I think that emerged from FAME-3 is that both groups, both the PCI and the CABG arm, did better than what was seen in historical controls like the syntax trial. You see here the FAME-3 FFR guided PCI arm not only outperformed PCI in syntax, but also CABG in syntax. And if we had seen a similar event rate as we saw in syntax, we likely would have met non-inferiority. Unfortunately, good for the patients, but not for the study per se, CABG did much better than anticipated. So some observations. What is the role of FFR guided PCI in patients with multivessel coronary disease in 2022? Well, for any test to be useful, one must first follow the results of the test. So if the FFR is above 0.80, then defer PCI. To optimize the benefit of FFR, it needs to be applied in cases where one is not certain about the significance of a lesion. Future Flower MI and FAME3 all included patients with very low rates of negative FFRs. There is a wealth of data supporting the role of FFR in patients with multivessel coronary disease. FFR guided PCI is still beneficial in patients with multivessel coronary disease as long as it is applied in appropriate scenarios where it's likely to affect decision making and as long as its results are heeded. Thank you for your attention.
Okay, so we're going to move to the second talk, role of CABG in multivessel disease. Jack Boyd, please.
Thank you, Dr. Park and Dr. Series. It's an honor to be here, and I'm excited to get the chance to talk to this group about the role of CABG in multivessel coronary artery disease, especially in light of the new revascularization guidelines and the controversy surrounding that. And also a lot of that actually stems from the ischemia trial. And I appreciate the group before handling left main. So for the purposes of my talk, I'm pretty much just going to exclude left main and leave it out of the discussion. I think a couple themes run through this, and I think we can see this from most of the talks on this topic, is people see what they want to see. And that, that's kind of an extension of beauty is in the eye of the beholder. I think another theme that runs through this, and if we think about it, is that the answer is frequently in the question that is asked. I used to think, at one time, I used to think I knew all the answers. Then with a little more time, I think I used to know some of the answers. And now after listening to many things, I'm not even sure I always understand the questions. I have no financial conflict of interest disclosures to make, but I did want to disclose that I've been involved in a few of the guideline writing committees for the AHA and the ACC in the past, so I'm familiar with the process how it works. I'd also like to disclose that I'm an adult cardiac surgeon, primarily focusing on coronary revascularization, and particularly interested in the hybrid procedure, including a robotically assisted, minimally invasive Lima to LAD, where the mammary is taken down with the robot. And then after that's done, the robot's withdrawn, small incision is made directly over the LAD. And then a hand-sewn Lima to LAD anastomosis is performed. Generally speaking, all doctors involved in the heart space agree in the excellent outcomes that come with a Lima to LAD. I'll start with the answer to my question is, what is the role of coronary artery bypass grafting in patients with multivessel disease? Well, I'd like to say that I don't think it's changed much in the last 50 years. The two goals of it are to alleviate symptoms and to improve prognosis. And the speakers before and after, I agree that this should be supported by data, and we should continue to study this. But also, I think we need to recognize that people see what they want to see in the data. So, as we investigate this, I think we need to look at the three main areas for the treatment of coronary artery disease. And those three areas individually have changed dramatically. The medical therapy wasn't even available in the first trials from 40, 50 years ago, comparing CABG to medical therapy. Percutaneous coronary intervention didn't exist at that time, and surgery was significantly different than it is today. So there have been significant changes, but there are some themes that run through and still hold true today. In evaluating this in the new revascularization guidelines, I think we should note, or what we need to focus on is the objections from the major surgical organizations. And the primary one from this is the downgrading of the class recommendation of CABG from 1 to 2B, primarily based on the ischemia trial, which was not designed or powered to determine a survival benefit from CABG. And even despite this, I think we can say when we put the curves up there that there was a trend towards survival in the early invasive group. Another objection is the apparent equivalence of PCI and CABG for decreasing ischemic events, despite adequate supporting evidence to do this. And finally, less important and not to be really covered today, is the class of recommendation 1 for radial artery usage without qualifications, not recognizing that it needs to be a high-grade lesion on the left side, a patient that won't be on multiple pressors coming out of the OR, and that has a good target with good runoff. So to evaluate these objections, I thought we should kind of just follow the roadmap of where things have been since the last guidelines in 2011. And the main leading point, or where the 2011 guidelines came from, was the syntax trial. And rather than getting all the curves, I thought we could just kind of look at the conclusion and go through it slowly and think about what it says there. So in conclusion, for the syntax trial in 2009, CABG remains the standard of care for patients with three-vessel or left main coronary artery disease, since the use of CABG as compared with PCI resulted in lower rates of the combined endpoint of major adverse cardiac or cerebrovascular events in 1 year. If we look at another subset of patients using CABG for multivessel coronary disease, we step forward to the STITCH trial in 2011, comparing medical therapy to surgical revascularizations in patients with multivessel disease. So in the primary evaluation, CABG did not significantly reduce all-cause mortality in these patients. The mortality in the CABG arm was 36%, and the mortality in the medically treated arm was 41% for a p-value of 0.12. But there were significant reductions, specifically in cardiovascular mortality, 28% versus 33%, reduction in death or hospitalization from cardiovascular conditions in patients that received surgical revascularization. And if you consider the as treated all-cause mortality, the patients that crossed over from medical therapy to CABG, there was a very significant survival advantage, 33% to 44%. So in the FREEDOM trial in 2012, so this was looking at revascularization, multivessel revascularization, PCI versus surgery in patients with diabetes and multivessel disease. So for patients with diabetes and advanced coronary artery disease, CABG was superior to PCI in that it significantly reduced the rates of death and myocardial infarction with a higher rate of stroke. So, so a quick summary of the FREEDOM trial. At 5 years, CABG had lower rates of death, MI, stroke. Its combined endpoint was 18.7% in the CABG arm, 26.6% in the PCI arm. Individually, there was a lower mortality of just under 11% to just over 16%. And there was a higher rate of stroke, almost doubled in the surgical arm at just over 5% and just less than 2.5% in the PCI arm. If we skip forward to 2015 and take a look at the BEST trial, a trial of everolimus-eluting stents or bypass surgery for multivessel coronary artery disease, we could see that among patients with multivessel coronary artery disease, the rate of major adverse cardiovascular events was higher among those who had undergone PCI with the use of everolimus-eluting stents than among those who had undergone CABG. And then about a year and a half ago, the ischemia trial, comparing an initial invasive or conservative strategy in patients with moderate or severe ischemia. They did not find evidence that an initial invasive strategy as compared with an initial conservative strategy reduced the risk of ischemic cardiovascular events or deaths from any cause over approximately 3 years. And then finally, most recently, just a little over a month ago, the FAME3 trial was published comparing fractional flow reserve guided PCI as compared with coronary bypass in patients with multivessel disease. And they concluded that in patients with 3-vessel coronary artery disease, FFR guided PCI was not found to be non-inferior to CABG with respect to the incidence of the composite endpoint of death, myocardial infarction, stroke, or repeat vascularization at 1 year. Now, this isn't a true meta-analysis. These were highly selected papers, but I thought I would do it from a journal that it seems like most of the panelists here read from regularly, or if not read from, at least submit their best work to. So I think these are highly relevant papers to this discussion. And a summary of these findings for the role of CABG in multivessel coronary artery disease is that 13 years ago, CABG was the standard of care for multivessel disease. 12 years ago, CABG had potential benefits to those with LV dysfunction. 11 years ago, CABG was better than PCI for those with diabetes, according to the STITCH trial. 7 years ago, CABG had fewer MACE than PCI with everolimus-eluting stents, according to the BEST trial. 2 years ago, no benefit was detected with an initial invasive strategy to investigating stable coronary disease with moderate to severe ischemia. And if you're like me, you kind of wonder, how does this summary fit into all the previous ones? And I think that begs the question of how is the ischemia trial used to justify the downgrading of class of recommendation for CABG from 1 to 2B. And finally, this year, FFR guided PCI was not non-inferior to CABG. So in summary, the role of CABG in the treatment of multivessel coronary artery disease hasn't changed much in 50 plus years. The medical treatment, the percutaneous treatment, and the surgical treatment all have, but the main goals are to alleviate symptoms and improve prognosis. Thank you.
Great. Nice presentation. You want to move next speakers, next talk, the role of optimal medical treatment in the multivessel disease. Dr. Bangalo, please. There we go.
Thank you very much, and thanks for having me on. It's been a wonderful session so far to hear about various different perspectives. I've been asked to talk about the role of optimal medical therapy in multivessel disease. And these are some of my disclosures. I have grant support for the ischemia trial. I'm also on the ACCHA guideline committee, but the views I'm going to express today are my own and not part of the guideline committee. So let's start with trying to see if I can move this panel somewhere. Okay, so let's start with the management of stable coronary artery disease. I mean, so this is the subject of my discussion, not acute coronary syndromes. So in terms of the options we have for patients with stable coronary artery disease, one is optimal medical therapy. And of course, the term optimal is now being replaced by guideline-directed medical therapy. And the way one would see this is it targets the culprit lesions. Culprit lesions are lesions which are angiographically or hemodynamically significant, but it also treats an 10 or 100-fold non-culprit lesions, because there have been a number of studies which have shown that for every severe stenosis, there is 10 to 100-fold less severe stenosis, but many of these are vulnerable plaques more prone for rupture. OMT is a good treatment for both culprit and non-culprit lesions. We do have bypass surgery. We heard from a number of speakers here. It targets culprit lesions, but as other speakers have pointed out, bypass surgery bypasses the first 2/3 of the coronary tree. So it does provide some benefit at any of the non-culprit lesion within that bypass segment. If it ruptures, it affords protection against an MI from that lesion as well. And finally, PCI. PCI mainly targets culprit lesions. We are stenting lesions which are hemodynamically or angiographically significant, and therefore does not target non-culprit lesions. So as such, in management of patients with stable ischemic heart disease, it's critically important to have optimal medical therapy. I don't think anybody on this panel would disagree with the fact that optimal medical therapy should be the backbone of all of the treatment of coronary artery disease. Because whether it's PCI, where it's very selective revascularization of severe stenosis, or even bypass surgery for that matter, even though it does bypass the first 50 millimeter part of the coronary tree, there is a part of the coronary tree which is not bypassed, which is prone for plaque rupture and for an MI. And as such, it's very important both for PCI and CABG that this be on the background of optimal medical therapy. So medical therapy should be the first line, even in those treated with PCI or CABG, to optimize outcomes for our group of patients. Why is this also important? Because if you look at data from a number of studies, the stenosis plaque characteristics does impact prognosis. For example, you can have, this is a right coronary artery with a severe stenosis, but there are also other areas which less significant stenosis. So if you look at severe stenosis, and especially if it is a severe fibrotic plaque, this is more likely to cause severe obstruction. And if there is not much lipid, but more fibrosis and calcification, this is more likely going to lead to exertion angina, positive stress test, and ischemia on a stress test. Of course, the way to treat this is to revascularize and also for anti-anginal therapy. Whereas if you look at all other non-significant lesions, many of these could be vulnerable plaques. They do cause minor obstruction, but they can have eccentric plaque lipid pool with a thin cap fibrous atheroma, more likely to rupture and cause acute coronary syndromes. And as such, pharmacological therapy to prevent this from happening is critically important, and also important to identify patients who would be potentially at high risk for such a thing. In fact, a historical perspective have shown from a number of studies, some of these are studies back in the 80s and 90s, suggesting that the majority of plaques that rupture and cause an MI are plaques which are less than 50% stenosis. So here you see that 68% of plaques that rupture are those which are less than 50% stenosis. So something that would not be targeted for by PCI. Of course, the nuanced perspective is from Greg Stone's study looking at various plaque characteristics. And we now know that it's not just the person's stenosis, but the amount of plaque, if the plaque burden is greater than or equal to 70%, and also which has a thin cap fibroateroma, these are also more prone to rupture and cause future cardiovascular events. And this would suggest that it's not just 50%, less than 50% stenosis, but you could have a lesion which is angiographically significant, lipid rich, and a thin cap which will rupture and cause future MIs. So as such, I mean, as we see from all of these, the guideline-directed medical therapy is critically important. I'm not going to go into details about data. We all know data in support of many of these interventions, but all patients with stable coronary artery disease should receive a set of lifestyle interventions. And this includes a behavioral modification, diet and weight loss in patients who are obese. Regular physical activity is critically important. If a patient is smoker, smoking cessation is critically important. In patients with known coronary artery disease, antiplatelet therapy with aspirin, high intensity statins, and of course, Mark Sabatini and his group has shown us time and time again in the last couple of decades how critically important lipid lowering therapies for these group of patients. And if the patient is hypertensive, controlling their blood pressure is important, and diabetic control is also critically important in patients with stable coronary artery disease. So the question we should be asking ourselves is, does optimal medical therapy modulate the survival benefit of revascularization in stable coronary artery disease? And of course, this was area of intense discussion, even with the guideline committee. But let's look at some of the data. I mean, we saw a number of studies being presented, but I like to look at it as whether they were, did it predate optimal medical therapy, or was it in the optimal medical therapy era? So if you look at the pre-optimal medical therapy era, there are a number of small trials comparing CABG versus no CABG. Of course, there was hardly any medical therapy in this time. So these are trials done in the 70s and 80s, and Salim Yusuf pooled all of these trials in 1994. Here you see that no CABG compared to CABG, or CABG when compared to no CABG, had significant survival benefit at 5 years. And it's important to recognize this. This was barely any medical therapy back in the day, but see what happens with the curves. You know, I've heard time and time again from a number of surgeons that just wait long enough, the curves continue to separate. But here, on the background of no medical therapy, the curves actually converge. There is still a mortality benefit of bypass surgery at 10 years, but the absolute difference diminishes at around 10 years, which is not surprising, because we know from a number of trials that other than the LEMA, there is a half-life of any of the other grafts that are placed. And you can see from the three major trials pooled here, two of them were not statistically significant. It was only driven mainly by the European study, but at least in the pre-optimal medical therapy era, CABG had a mortality benefit compared to no CABG when there was hardly any medical therapy. Now, if we fast forward to patients in the medical therapy era, we see a consistent message across trials. I mean, we are not talking about composite endpoints. And I think that is one of the biggest problems we face in the field today, that people have this broad outlines of CABG being superior, or revascularization is superior, without going towards each particular endpoint. But if you focus on mortality as an endpoint, the message is very consistent. Courage trial, no difference in mortality. Barry-2D trial, no difference in mortality. Even the FAME2 trial, which is largely viewed as a positive trial for PCI, if you look at survival, there was no difference in death between the two groups. What about ischemia and the ischemia CKD trial? Again, no difference in survival. Again, I want to point here, there seems to be a lingering confusion that there is separation of curves in favor of invasive for the endpoint of death. This is the curves for death for the ischemia trial. Again, the two curves are superimposed. There is no crossing over curves, etc., up to 5 years of follow-up. In the trial that I led, the ischemia CKD trial in patients with advanced CKD, again, no significant difference in mortality between invasive and conservative strategy. We pooled all of these. It's a meta-analysis of randomized trials of routine revascularization versus initial medical therapy in the medical therapy era. And from all of these trials, the one message seems to be very consistent, that if you look at death as an endpoint, there is no significant difference in death between revascularization and medical therapy. Now let's fast forward to triple vessel disease patients, and which has created a lot of confusion. So if you look at triple vessel disease patients back in the day, 1980s, where there was hardly any medical therapy, in the pooled analysis, if you opt for CABG when compared to no CABG, at around 8 to 10 years of follow-up, there was an extension in survival in the triple vessel disease group. And this extension in survival is of the order of 6 months. So if you chose CABG when compared to no CABG at 10 years, 6 months extension in survival with CABG. Now, let's take the same CABG group of patients. Forget PCI for a second and look at Barry-2D. Barry-2D trial enrolled patients with diabetes, multivessel disease, and the CABG stratum. Most of these patients had triple vessel disease, and now you see the mortality curves for revascularization and medical therapy. Revascularization is CABG. So here there was mortality benefit in the 1980s, 2009, with more optimal medical therapy. You see that the curves are really superimposed. There isn't much difference. I mean, you do see some separation later on, but really there isn't a significant difference. So whatever we said in the guidelines has less to do with ischemia, but overall totality of data from if you exclude very old trials when there was hardly any medical therapy. What about in ischemia trial? So this is the results of ischemia based on CAD severity based on coronary CT, 1, 2, or 3 vessel disease. There was no significant interaction. There was no significant difference in 5-year event rates between invasive and conservative strategy. I just want to add this as what about our ischemia results applicable to CABG? There is this narrative that ischemia is a PCI trial, but if you look at all of the revascularization versus medical therapy trials, ischemia, there were over 500 patients who underwent CABG, and there were, in fact, this ischemia trial has more patients who underwent CABG than any of the prior revascularization versus medical therapy trials. And in fact, it's more number of patients who underwent CABG than the 3 trials back in the 1980s, the individual trial. What about the fact that CABG reduces mortality? This is true, but it's only true in very older trials when there was no medical therapy, but the curves converge at around 10 years. How about the notion that PCI does not reduce mortality? And we and others, and even in the ischemia trial, we showed that both PCI and CABG reduce MI. Okay, so just going back to a question, that does OMT modulate the survival benefit of revascularization in stable coronary artery disease? The answer seemed to be yes, and there is a diminishing mortality benefit. I'm not saying there is no mortality benefit, but if the patient is optimized with medical therapy, the benefit is likely going to be less. But let's talk about the more important aspect, achievement of OMT goals in randomized trials and impact on prognosis. This is data from Patrick Seruis's SYNTAX trial, use of OMT post-revascularization in SYNTAX. Interestingly, SYNTAX, as all of you remember, randomized patients to PCI versus CABG. And at baseline, only 29% were on optimum medical therapy before revascularization. And of course, OMT here was defined as being on an antiplatelet, statin, beta blocker, and an ACE or an ARB. So only 29 before revascularization. After revascularization at around discharge, there's more patients on OMT in the PCI group than compared to CABG. And I think this is what the other speakers were also emphasizing, that we need to pay particular attention around this point, both PCI and CABG, we need to maximize their medical therapy. And interestingly, if you look at what happened at 5 years, only a third of these patients were on optimal medical therapy in either of the groups at the end of 5 years. Does this make an impact? So here is the outcome data. This is mortality in the SYNTAX trial. And regardless of the time frame, when you compare patients who are on optimal medical therapy compared to those who are not on it, of course, this is not a randomized comparison. There are a number of limitations. But what this shows is there is a 36% relative reduction in mortality in patients who are on optimal medical therapy at 5 years compared to not on medical therapy. And this relative reduction is greater than the relative reduction of mortality with CABG when compared to PCI at 5 years. This is not the only trial, BARI-2D trial. If you look at the risk factor control, the definition of risk factor control is here. They required the 6 components. And if you look at patients who achieved all 6 components, it's less than 15% at 5 years. So it's around 15% of patients had all of the risk factor control at 5 years in the BARI-2D trial of PCI of revascularization versus medical therapy in patients with type 2 diabetes. And again, in the BARI-2D trial, we saw this gradation. If you have a patient who have 0 to 2 risk factor under control, compare that with the gold standard, all 6 factors under control, you see a graded increase in outcomes. And this is increase in death with more number of risk factors not under control. Again, emphasizing optimal medical therapy is critically important in these group of patients. And BARI-2D also looked at individual risk factor goals and whether there was an increase in death when the particular risk factor was out of control. And you can see whether it's non-HDL cholesterol, blood pressure, diabetes, etc., all of them did play a role. And if those risk factors were not under control, you had increased risk of cardiovascular events. I mean, we may all say that we have known this from a long time, that medical therapy is very important. And this is data from the CAP PCI registry, looking at optimum medical therapy goal attainment prior to publication of Courage and post publication of Courage. And we see that these numbers have really not changed. So we really need to do a good job at improving these rates. In the ischemia trial, of course, we had a set of guideline-directed medical therapy goals, which included behavioral therapy, physiological blood pressure goals, including blood pressure goals, LDL cholesterol, body mass index, and diabetes, and pharmacological agents. I mean, the goals were based on best available evidence when we started the trial, and we evolved it as the trial progressed, and we had newer data for PCSK9, etc. But just to summarize what we did in the ischemia trial, it's important to recognize that in the ischemia trial, 95% of patients were on statins. 2/3 of the patients were on high-intensity statins. The median LDL achieved was 64. And of course, now you see that in many high-risk patients, my preference for LDL goals is even lesser, less than 50 or 55. And the systolic blood pressure we achieved was around 129 millimeters of mercury. And this slide again shows what happened in the ischemia trial. So any statin was very high. This is baseline. This is last visit, 95%. 2/3 were on a high intensity statin at the end of the trial. But what I want to point out also is the fact that if you look at all of these goals, and we used a metric called a high level of medical therapy optimization, it was 20% at baseline, improved to 41%. So in other words, more than half of these patients were still not at control, despite the fact that we made significant efforts to improve these goals. I know I showed a lot of data, but to summarize, I think the panel would agree that optimal medical therapy is critically important in patients with coronary artery disease, whether it's single vessel, multivessel disease. Atherosclerosis is a systemic condition, and as such, systemic treatment, which basically is optimal medical therapy or guideline-directed medical therapy, is fundamental for optimal management, even after revascularization. And let's not forget OMT in patients post-CABG. OMT should involve lifestyle behavioral risk factor goals, physiological goals, and select pharmacotherapy. And I must say, I mean, I didn't show data. This is an evolving field. Dr. Sabatine, Timmy Group, and various others, they're testing many different therapeutic approach. And I think this field is going to continue to evolve, and efforts should be made to optimize goal achievement and also adherence. And thank you for your attention.
Great. Nice talk. So we have the limited times. However, we want to have some discussion. So one of the two lecturers, Dr. Bode and Bangalore, and Tristan, the panelists, that will discuss some issues.
I'm happy to start just because I know we only have a minute or so left. I think two fabulous talks. I think it really underscores the importance of giving optimal or guideline-directed medical therapy, and that's hard to do, as you've shown. That even though we know we should do it, the rates remain depressingly low, because it's, as we'd say, it's a slog to do it, to get the patients to take it. And but it requires a lot of work. I think that regardless of what revascularization approach may or may not be beneficial for subsets of patients, that absolutely does need to be the foundation. So I'm glad that was emphasized.
Any comment on that from Patrick?
No, I think the only thing I can say is that not so long ago, we have published the follow-up of the 5 years, assuming that the people in syntax who were still on OMT at 5 years would continue for 10 years, okay? It's an assumption for what it was. But it was amazing to see that the OMT between 5 years and 10 years we are completely diverging from the non-OMT. I think we have published that in one of the journals, but the curve were phenomenal. I mean, how the curve diverged between OMT and non-OMT. That's really something we have to do despite the maximal revascularization. And you know, there are currently a trial that we have started with Oxford on the use of inclisiran, the subcutaneous injection of inclisiran to block the production of PCSK9. And it's sure that if it works for primary prevention, that's also something we should be add to our patients who have post-PCI and post-CABG. You will remember that I did the LIPS trial, which was the first trial post-PCI where statin was obligatory, mandatory, whatever your level of LDL cholesterol was. And that was a great success, the LIPS study, with a difference in mortality on short term. I think it was 4 years, I remember. So I'm really a pro about medication after PCI. And if the price of these new drugs is not overwhelming for the healthcare, I think that drug like blocking or inhibiting the PCSK9 will be part of the pharmacological armamentarium in this decade. Somebody has to do the trial.
Any other comment on that one? Or we have lots of issues, so, to be honest. In fact, we have not much data about survival benefit of bypass surgery and PCI. Actually, in the interventionist side, it's very limited. I realized a very limited field of PCI revascularization. The reason why everybody, realize that they're symptomatic and we're gonna have to concern about the survival benefit. We have to compete with the bypass surgery, the PCI versus, bypass surgery. However, very limited data. However, depending on, according to the ACC, last year's age guidelines, the most important factor for survival determinant is ejection fraction, right? From the older study, CAS trials, Stitch trials. Anyway, they discriminate with a cutoff value of ejection fraction less than 50%. There are some revascularization may have some benefit. However, more than 50% of ejection fractions, normal ejection fraction, still we have think about a lot of issues, medical treatment, even in the PCI versus surgery concern. So, Dr. Jack Boy, you're a surgeon, and so any comment on that one? Right.
Yeah, okay. Thank you, Dr. Park. My comment would be, when I work with my patients and, when the team has agreed that revascularization is appropriate and it's surgical revascularization, what I tell the patients is certainly the surgery is a notable time, but really where they're going to get the biggest, best, and longest benefit from it is from getting to and adhering to, goal-directed or optimal medical therapy. So I think the data is pretty clear that the treatment of coronary artery disease is going to involve medical therapy and then at times revascularization. And then you can pick and choose your revascularization strategy based on potential benefits and downsides to individual patients. But the lifestyle changes, the risk factor modifications, the goal-directed medical therapy is where you're going to get the biggest bang for your buck, because we do recognize that the curves come back together, that bypass surgery unfortunately does not convey immortality on our patients. But we do look for that area of the curve where we can separate things, and we want that to persist for as long as possible.
Hey, Dr. Ang.
Yeah.
I have some, phase 3 study. So why, we have to consider the FFR for the multivessel digit. However, the conclusion is not inferior. You cannot overcome the PCI limitation. So could you explain that one?
I think Dr. Ferron explained already, but based on the data, the FAME3 trial used FFR to decide the functional significance in the PCI arm, but unfortunately, among the inpatient enrolled trial, 80% of patient lesions already FFR is less than 0.80. So the most patient enrolled in the FAME3 trial already functionally significant. This number is very higher than the previous FAME1 trial. So FAME3 trial, even though they use FFR, but it is very similar to the previous angio-guided PCI versus bypass surgery. So the Kaplan-Meier curve is very similar to the previous our random trial based trial. So in FAME3 trial, the FFR may not work to decide the revascularization decision. So that's why the FAME3 trial is not inferior to the bypass surgery.
Yeah,
that's my interpretation.
Yeah, what we saw in the FAME3 is okay, a relative good selection of vessel to be treated. I mean, that was the key point of that trial, but unfortunately, it's a pity that the FFR of IFR was not used to assess the quality of the revascularization. That's point number one. Point number two, it is amazing to see that after syntax 2, where there was 86% of IVUS, that the percentage of IVUS in FAME was 12 or 14%. The same percentage has in syntax, the original syntax. So clearly the attempt to optimize the work was not done. A comment about Bangalore presentation, I think that whenever you see curve of survival converging after 10, 12 years, you have to make the difference between survivor and survival, yeah? Because basically the area under the curve give you an idea what you have achieved, at least in the first 12 years, yeah? I think it's an important trial. I just finished an editorial on that point because I receive a letter of readers asking me the difference between these two concepts.
All right, correct. All right, see you.
So let me bring up one last point, and this kind of fits in well with the first part of discussion where we were talking about survival and quality of life, because I think that, in my own opinion, there's been a lot of misinterpretation about FAME3. On its face, the results are very, very clear. But there are two factors that are trial specific that totally drive the results. The first was the definition of procedural myocardial infarctions. And they used a sensitive definition of procedural MIs and got the result they got. But they also reported the SCAI definition of myocardial infarctions, which are the larger, more prognostically relevant MIs. And that was substantially less with PCI than CABG. So just had they changed the procedural MI definition, it would have, the outcomes would have been almost identical between the two groups and non-inferiority would have been met. So that just shows you how we're still stuck, number one, with this morass of what definition to use for procedural MIs and how it can totally change the results of trials. Number two, a major component of the endpoint, in fact, the most common difference between PCI and CABG was repeat revascularization, which was about 2% different between the two procedures. But, you know, repeat revascularization, most of those are elective procedures, most are outpatient procedures. They didn't include repeat hospitalizations, which was reported between 30 days to be 5% more with CABG than PCI. So this totally gets down to the fact that, you know, had they done that and used the SCAI MI definition, PCI would have been superior. So there can be, you know, you can get totally different results of these trials depending on what you use for your primary endpoints and the definitions you use, which is why I think we as a field, we need to move more towards, in my opinion, survival and overall quality of life. And not just at one time point. We have to look at quality of life early, intermediate, long-term, both disease-specific, non-disease-specific, because we need better metrics to be able to describe the whole patient journey rather than just using these discrete, very definition-dependent outcomes, which vary according to the whim of the investigators.
I agree.
Okay, great. All right.
Dr. Park, yeah,
Robert.
I think the discussions highlight what a difficult job the guideline task forces have. And I know there are discussions that we have all the time, but on the other hand, they really have to consider the totality of all of the evidence, consider the representation of patients, be slow to change, be cautious to change your recommendations. And then on the other hand, there's increasing pressure to respond in real time as data becomes available and adds to the evidence base. So it's a challenging task in relation to the controversy relating to CABG and the downgrading of the evidence. Certainly it highlights what a difficult job that the task forces have, but I think it continues to be important that we work together. We know our everyday practice is working together with our surgical colleagues and try to work to achieve consensus across the professional societies. I mean, the issue of patient selection is one that I come back to, and we look at the ischemia trial and we look at the very low mortality in the ischemia trial, and then we have to ask ourselves, is this a function of patient selection, or is it just because, as we saw from some of the data presented, that a really good job has been done in optimizing the medical therapy of these patients? We know from the vulnerable plaque data sets, we know from the sudden cardiac death data sets that plaque burden is a major determinant of outcome, and perhaps we're just doing a much better job with optimal medical therapy.
Another comment, if that's possible, on the endpoints that we are not catching up in these randomized trials is that when we look at mortality from 5 to 10 years and we see no difference, we are not catching up the acceleration of disease that is occurring in the arteries when we put in a venous graft that is shutting down. In daily clinical practice, we struggle a lot with this calcification in the genuine arteries when the venous graft is shutting down. And these endpoints are not caught from beyond 5 years and onwards because we don't have the resources to follow these endpoints. So I think when we sit in front of the individual patient, we have to think of the lifespan of that patient. We cannot catch everything in the first year, in the first 3 years. We have to think all the way. Some patients should not have the lemur in the very early phase of their life. We sometimes should postpone the lemur to a period where we will expect that to be patent for 20 or 30 years. So I think we should also take that into account when we discuss surgery versus PCI.
All right, great. We have not enough time, so any discussion point or comment on that? Okay, I'm very happy to have you all of this TCTAP 2022, especially very hot discussion side, main and multivessel PCI. I'm very happy to have distinguished speakers and panels too. I'm very, happy and appreciate again. And maybe next year's meeting, so we're gonna meet face to face after the pandemic. Thank you for you joining us.